Well, good morning, and thanks for having me in Southampton. I'm really pleased to be here and talk you through the evidence base. It's a big evidence base, so I'm not very able to give you everything, but I'll give you lots of websites along the way, and hopefully you'll be able to get a copy of the slides where there's details and websites attached. Also, there's a couple of reports coming out that I can make available to you, and Lily mentioned one of them, and there's another one that's quite recently. But I'll pick these up as I go. So, it's a flavour, really, of the evidence. I'll just start, though, by saying who we are at the Mental Health Foundation. I'm not sure if everyone knows who we are, but we've gone through a bit of a refresh as an organisation, and I'll come to what our general approach is in a second, but just share with you our vision. So it's a world with good mental health for all. So you can see the word all's in there, and for us that means that it's not just about people with mental health problems, it's making sure that mental health is recognised as an issue for everyone, and that we do what we can to prevent mental health problems in the future. And our mission is to help people understand, detect and sustain their mental health. So we don't provide ongoing services. What we do, this is a challenge. If I put on my glasses, I don't see anybody in the front door, and so they'll be on and off. So what we do is we connect policy, research and practice and services, communities and workplace. We're very much about the impact and working our way back from there. We take an evidence-based approach as an organisation. That's absolutely to the core of who we are, but we want to actually see things happen in the community and not write reports for report's sake. We develop programmes and work with partners across the UK and beyond that change lives. So we also don't just say, here's what might be your best buys. We also pilot and test and evaluate some of those and make that evidence available as well, and work with partners to try and get things embedded, get different programmes and approaches embedded. We nurture and amplify the voice of experts by experience, especially those most marginalised. So we're doing a lot more of this in England and Scotland. Probably that's been our flagship for this work, where we run the National Service User Organisation. We do the same in Wales, but we also run a fair number of networks and groups for people like refugee women, and so we do more of that in England as well. And of course we have our big Mental Health Awareness Week campaign, and we hope to be able to up the ante with our campaign and get a lot of the evidence out there in very accessible ways to people. So that's it, that's all about who we are. I'll head on to the meat of the bones here. So exactly the same as Lily, and it's always the same when Lily and I present together. Some of the slides overlap, which is a good thing. So we also adopt the WHO mental health framework for years, for really as long as I've been on the foundation, for 13 years. We've seen ourselves as a public mental health organisation, so we've been concerned with promotion, recovery and prevention. I think I've grown the prevention bubble here because in the next 5 years within our strategy, our aim is to focus down on prevention. And a reason for doing that will become clear as I go on, but it's because we really want to get to those high risk areas and where the greatest prevalence are, and where we could, as a smallish organisation, medium-sized small organisation, we want to be able to get to those areas where people are having the greatest challenges. So why prevention? Hopefully most of you will know this, but I'll just quickly flip through. Increase in mental health problems in children and young people. We know that that's a vital age where mental health gets established, and mental health problems. Adverse childhood events are a huge predictor in terms of mental health outcomes for people later in life. So some of the indicators of that, school exclusions are on the rise. We've got more people than before on the child protection register. So some of the social, environmental issues out there are indicating that things aren't good for people. But even if you're not at that end of things, and actually your child is doing reasonably well at school, you're still likely to have one in 10 times have been bullied. One person in the class is likely to have lost a parent, and 10, a third are likely to have been seen their parents separate. So lots of issues there that can impact on mental health. So for that reason, we feel really if we're going to lick what we reckon is our greatest mental health challenge of our time, we've got to swim or fish upstream. So we need to do a bit better at actually trying to stop things happening in the first place. And And by that very much mean really what Lily was talking about earlier, about that, the idea of primary prevention, stopping mental health problems happening in the first place, or preventing them if we can. Secondary prevention, looking at where the highest risk is for people, and then but also still that tertiary intervention, where somebody's had an existing mental health problem and you want to support their recovery and stop any further social losses, health losses, all the negative things that come out of having a mental health problem. We know dying 20 years younger, if you fall out of work, there's a really good chance you won't work again if you fall out of work with a mental health problem. So I very much see that prevention overlaps quite considerably into that recovery area. So, of course, we want to work in childhood, and we do a lot of work in childhood, and you'll see as I go on, the evidence base is pretty much strongest here for this area of work. And that's because there's lots of statutory duties, which I'm sure most of you know about, and there's lots of, but I think key to this is there's those opportunities to intervene, there's those opportunities to make, I'll use this bit of jargon a few times and then explain what it is, but make every contact count as you go. So, but we can't just work in childhood, and that's a nice 30-year investment, and we absolutely should be going there. However, however, that does mean that we would be ignoring all the distress that people are having just now and all the issues that people are encountering just now. So we know that it's an adult life often that problems manifest themselves properly, and also adults are going to be parents of the children, so it overlaps back. But also in later life, if you've experienced a lot of adversity in life, that's where it comes home to roost. Even if you haven't, even if you've had a good life and felt that things have gone well for you and you've been one of the lucky ones, then you could find yourself really isolated in later life. And we know that if you're isolated and your expectations of social connectedness are high, then you're going to experience loneliness at a greater level. So, and that can happen through having dementia, through having a long-term condition, things that are not necessarily within your control. So we very much promote, just as Lily was saying, a life course approach in the work that we do. And those bits in the middle, those arches are about really our way of trying to protect that the transitions are really crucial. Transitioning out of one stage and getting through the barrier into another are points where we often don't focus enough. I'll come back to that though. So in the foundation we very much adopt a whole system approach, but it's not new to us. This is taken very much from public health, and Marmot and others in public health, WHO, have talked about this approach more generally in health for a number of years. So what's crucial about it is that we could do a lot of work around prevention, and we could just focus on doing a lot of universal activity. So we could look at doing lots of work within schools around school culture and school ethos. However, what that's not going to get us to are the people that are more at risk. So, and it's not going to get us to the people who already have mental health problems or have shown signs of distress, where there's really a need to intervene now and intervene early. So whatever way you want to put it, this is very much Marmot's work, proportionally targeted, universally proportionate, progressive, whatever approach. That you do some things for everyone, absolutely, because you just don't know who's going to be in that selected, well you do know to some degree, but you can't predict everything, so you don't absolutely know who's going to be in that selected group in the years to come. So you do some things for everyone, and then more for people who are at much higher risk. So this is very much the work that we've been doing in Southampton, using a framework which I've not put in my slides because I'm very aware of Lizzie, or David, you probably have them in your slides, but it's based in this model, which is a whole community approach to public mental health. And what we're really saying there is a number of things. Sorry for the wee smiley face in the middle. We're trying so hard not to make it gender related, but I do need to find some other way to depict that. And I think we'll probably expand that to show somebody going around the life course, so that the life course is in there as well. But what we're really saying is that we need to adopt a socio-ecological model. We need to learn from public health and actually recognise that people live with families, and your own individual health behaviours are only part of the story. We can't just give people information and hope they'll change their health behaviours and all will be well. Actually, a lot of things are out of people's control, and a lot of adversity and a lot of difficulty start in the home. Also communities, and I'll come into all the different areas and in communities shortly, where people live in their neighbourhoods and all the communities that they belong to, and then what happens at a national level impacts greatly. So whether it's talking about DWP, absolutely, we're going to be able to lift some of this, and we're going to be able to work to prevent mental health problems. We do need to start looking at those wider policies that impact on mental health. So we need to be thinking about the places where mental health is determined much more than we have to date. If we only think about mental health services, if we only think about mental health policy, it's going to be really difficult, if not impossible, to work to prevent mental health problems. Because much of mental health is determined, as I said, in your homes, in your schools, in your workplaces by national policies. And so mental health in all settings, very much thinking about how this can become everyone's business. So mental health in all settings would be schools, workplaces, how can we embed it all the way through? And in that way, we talked about universally and everything that happens, but also, you know, some more targeted work as well. How can we embed it in all those services that people have contact with? So we know there's a huge correlation between, you know, you're much higher risk of having a mental health problem or being depressed in particular. If you've got a physical health problem, equally, if you've got a mental health problem, depending on the mental health problem, you can die as much as 20 years younger. So there's real health inequalities that we need to consider. So we need to get into primary care in some of those areas. Mental health and all policies, I think I've explained, but also the measures. Our measures of success, we're going to see if this is working at all. We're going to have to think much wider than just bed numbers, and I'm not suggesting by any manner of means that we only think about bed numbers, but we need to think about things like conduct disorder, attendance at school, attainment at school, employment, presenteeism, absenteeism, some of those are wider indicators as well. And of course, the model assumes a life course approach, and that we address inequality and genuine co-production. I'll say a lot more about co-production in a minute. So you'll see as I go through, some of the evidence is about what we know about what works in prevention, and some of the evidence I'm bringing today is what's worked in public health more generally that we could apply that's not yet necessarily been tested in mental health. So the evidence, starting with individual parents, but then also the family unit, there's a number of really strong evidence around home-based intervention for maternal mental health and to promote attachment as well. So this is just one systematic review that I've put up there, but this is just one big study that I've put up there. But that's got pretty strong evidence that's a best value really. And that can include peer support as well. It's not necessarily a health visitor, it's a role that's got good work with health visitors as well. Creation of effective perinatal pathways have been recommended by NICE, so that you're actually people who are at higher risk are being picked up, been identified in the first instance, and supported to have a smooth transition into the services that are right for them, but also around picking up suicide risk. Parenting support to promote attachment, huge amount of work in this area. There's some systematic reviews, a lot of it's individual random control trials, but there are a lot of studies. So I've given you a list of some of the more common parenting programmes there, and there's a website that kind of summarises all the parenting programmes. Some, not that many, but some have been applied really well to high risk groups, so people can be in communities, LGBT parents, they're more isolated, so there's a number of areas, parents with disability that picked up, and addictions as well, I think is very much been in there. But the website address is there, and the link's there if you want it later. This is a bit emerging, so but I've put it in here because I do think it comes out of the evidence as being a key indicator of how well a child will do at school, socially, emotionally, and in terms of attainment, is how ready they are to attend school in the first place. So NSPCC has started to grapple with this, and they've done a study. There's been a review, an evaluation of an approach that they've used that's shown really, it's indicating some really successful outcomes for people. But it's an area, probably later on when I show you the areas that are more promising as opposed to more fixed. It probably fits in there, but I've cheekily put it in here with the evidence because I do think the evidence does say it's something they need to look at. Systemic practice and whole family solutions are what Tavistock Centre's calling for. And for any of us that worked in services, and certainly most of my career has been working in services, way back working in adolescent services, this is exactly the approach you took. I'm talking 20, 30 years ago, this was the approach you took. So there's nothing really new about this. I guess what's new about it is that we, perhaps in wider settings, maybe we've not applied it to the same extent, and it's certainly become a bit more individualistic, but certainly systemic approaches have got to be crucial. Children can't, and they can't control most of their home environment. Most of that's down to who they live with and that parent relationship. So Tavistock say couple relationships, be early intervention opportunity. The couple are managing things well and have a functional relationship. That'll help. And just in case we need any more convincing as to why this is a crucial area to look at, 4,500 children seen the CAMS, and this study said the biggest presenting problem of family relationships. So I think from the horse's mouth, so to speak. So instead of going for older children, what I've done is looked at schools, because I think in terms of that model it's a really interesting one, because schools are full of individuals, but it's also a community. It connects, if it's doing its job well, it connects in with the family. It's part of the wider education structure, so it goes all the way through that socio-ecological model. But it's also a setting that runs right through it as well, and there's lots of micro-communities within a school, so I think it's an interesting area. And why I think it's one that there has been a number of studies in is because, a bit like prisons and various other places, you're a bit of a captive audience while you're in school, so there's a real opportunity to do some good as well as to do harm. So there's debate about how strong the evidence is, but economic case for bullying programmes is good, and certainly there are variables about how good certain programmes are, but certainly in terms of your top investment, there's agreement with that. If you could only do one thing, do a really good evidence-based bullying programme in schools. So Martin Knapp has said that's a top investment. And then I'm going to swiftly go on to whole school approach, because I think it embodies that model I talked about, and this has probably been the only place it's been completely applied to date, is the whole school approach. And NICE recommends the whole school approach, and it's got a number of positive impacts. Some of this is interesting because you see the first one is academic learning. There's been a lot of national debate about whether we should be focusing on the mental health of children at school or just pushing the expectation of attainment up. And certainly some of the debates for the government has been push the expectation of attainment up. That's the most important thing. And in actual fact, the evidence does show that you do well by children's mental health, attainment will go up. So focusing on attainment seems to be, and we don't know yet, but certainly from certainly the Children and Young People's Champion and lots of other anecdotal evidence that we're getting, actually the pressures at the moment with the extra exams and pressures on expectations of children's actually counterproductive for mental health. So I think that's an interesting one. Also staff well-being in a whole approach, a whole school approach, or whatever kind of whole community approach you're using. The people that hold the power are often struggling themselves, and we'll probably all recognise that from our own practice, our own working services, that at times when you're not doing so great yourself, it's really difficult to do well by other people. And so improving staff well-being, teachers need to be in a good place themselves, and we know that that's not the case at the moment. Prevention of mental health problems, so that's obviously quite key to that as being one of the positive impacts. And then also, because it's not just prevention of mental health problems, I think it's really important to remember that somebody might not be diagnosed with a mental health problem but not be flourishing at all and have poor mental health that goes on to result in a whole load of other risk-seeking behaviours or not exactly coaching for behaviours, let's say, behaviours that are difficult for society to cope with. And I think it's interesting to think about this whole setting approach where it could be used elsewhere, and I'm giving some suggestions for that and pull out the bits of evidence to let us get there. But in case you haven't seen it, as I said, this will be in the slides. I'm not going to go through this, but that's the whole school approach, what it looks like. It's got the targeted elements, but it's also got the whole ethos and curriculum, and students' voices being part of that. I think that's another crucial part of things. But also within schools, there are lots of communities, and often, and we know there's been a fair bit of work with children and young people, and particularly teenagers, are saying their peers, it's all about their peers, and that's where they go to first for support. So I think it's worth saying that peer support should really be in there in that whole school approach, looking for ways that peers can educate and support each other, whether it be around stigma and discrimination, whether it be around mental health literacy. And there's been increasing attention given to this area of peer support. I mean, children are saying quite clearly this is a key area for them. Said that. And the SHARP paper says that bullying, well, it's a bit mixed, but it's looking good. But the next thing that's looking really good is peer support. So 3 things that you could do: peer support, whole scale approach and bullying. And if you can do the whole scale approach and build in bullying and peer support, that would be ideal. And just an example of where one's happening in Somerset, where they're using an Australian approach to peer support. And I want to show you this. This is a wee GIF. I'll just let it run through. It should run through itself. Yes. This is something that we could use with. We've done a big project with Greater Glasgow Health Board, looking at children and young people, and it's been co-produced with children and young people. And what they said is they want a really accessible website and gifts of what they thought were the best way to get advice. So they've designed loads of gifts, and what they can actually do is go on and design these live as well on the website. And so there's a whole range of stuff. Bit of it's gone a bit over my head, but it seems to be something that's really, really valued. And I'm just going to show you one other quick thing that I think is important is I don't know what's happened to our logo there, but anyway, ignore that. We need to also remember that not all children are in school. I'm sure we wouldn't forget that. Some children are excluded from school, some children are in care, but also there are children with long-term conditions out there, and we've done work with children with long-term conditions, and they felt particularly excluded and without a peer group. So bringing them together as a peer group, so finding ways to bring people together who may have a mutual interest, may have a mental health problem, or may have a long-term condition, I think it's important. And this is an advert, a campaign that they developed for schools with us, and this is very much what they were saying is that phones are taken off and they go down the front of the class, and they were saying, well, actually in an emergency that makes me really anxious, really stressed. So looking at the whole community approach, the whole approach, I've just kind of worked that through in terms of a mentally healthy workplace. Now there's evidence for various different aspects of this, but there's very few people who've done the whole thing, and it's certainly something we've been working on. It's not been a model that's been applied to this to a great extent. And about 7 or 8 years we developed guidance, we developed European guidance, which was based on taking a whole workplace approach. And it's been picked up probably more in Europe than it has been in the UK. But again, universal. So NICE say the most important thing you can do if you can only do one thing, the best buy would be line manager training. That's the area that you're going to get the greatest gains. You see a lot of this is exactly what you'd be doing to be a good employer anyway. Some of it's not that different to mental health, but I think when it starts to get different is when you start to go into the more at risk areas. So thinking about bullying and harassment in the workplace, absolutely crucial. And again, there's some growing evidence around addressing bullying and harassment in the workplace, but also recognising those pressure points. So people who are at higher risk, people in low-paid jobs, 0-hour contracts, etc. People who work night shifts. But also, I think it plays out quite well when you think about if you just took a universal approach, what you'd find is people who are part-time workers or who work night shifts would be less likely to come to your mental health awareness sessions. So it's really crucial to start thinking about how you target down and provide extra support there. But it's also not just about people who might be at highest risk. It's also about points in people's lives, if they're separated, divorced, heading towards retirement as well, or if there's huge change process happening in the workplace and really difficult things happening around HR. And indicators. So recognising and addressing distress. So it's not just people with mental health problems, and I think often the language of distress can be easier to use in the workplace because you really don't want your HR manager going and diagnosing people or getting into people's clinical care. What you want them to do is be able to recognise when someone's struggling and be able to take very human, compassionate steps to support them and help them to through that pathway to support, to make reasonable adjustments and to work with them to think about what those reasonable adjustments would be. Also tackling stigma and discrimination in the workplace. I do a whole workplace bit, and I'm not going to go into all that now, but there's stats that are appalling about employers and their views on people with mental health problems in the workplace, and also the barrier it causes in terms of people's own thoughts about disclosing. So there's still major issues there. And supporting people back into work after they've been out of work, and some really good evidence around problem-solving approaches, CBT, actually getting people back into the workplace as quickly as they can without them having a long time out of work. And there's varying different stats around this. The worst stats I've seen have been 89% of people falling out of work through mental health problems will never again work. So if we're anywhere close to that, that's pretty worrying. So on to a whole community approach, so a whole Southampton approach, a whole Devon, a whole area approach. This is what we've been doing with Lily in Public Health England, looking at the task force. We worked on drawing together the evidence, but very much of a practical lens that we were looking at it through, thinking about what the recommendations could be in the task force report. So mental health literacy, Lily's already talked about, but there's some key drivers there already, some levers there already, like making every contact count, where we could really pull out all the stops to make sure that has an impact. So that the people who have whatever service they attend, for a physical health problem, people are thinking about their mental health. If they attend for a mental health problem, people are thinking about their physical health, people are thinking holistically. Co-producing messages alongside local communities, again, co-production's a big theme in this, but we know we're not reaching a lot of people in communities, and the answers that people have found in community development and in public health more generally is you need to really work with people to not just work out the solutions, but also to work out how you communicate those solutions to people and how you engage people. And also, a lot of people don't want to get their messages from a professional. A lot of people want to go online and find them for themselves, or a lot of people value that peer aspect. Somebody else has gone through the lived experience. In fact, many people value that aspect, sort of giving advice and support and information. And just another example, the paper that Lily's talking about that will be coming out soon that they wrote jointly together. We've put a number of international and interesting case studies in there for people to be able to reference, and this Australian approach is every service is a gateway principle. It's actually worth looking up. We're going through a lot of detail. There's a real framework there about how you do this stuff. And then more generally, creating mental health communities. I'm not going to say any more about a whole community approach, but it's very much Marmot's view about taking that a bit progressive approach. Applying an asset-based community development approach. Sorry for using the word approach too often. If anybody can think of anything other than model, I can use instead. I'd be much obliged. So there's a really good evidence base around asset-based approaches, just not in mental health. So I think this is something maybe we could change. And social prescribing, again, there's a number of studies that have shown that to be useful, and that sits very well alongside asset-based approaches, because of course social prescribing is about looking at what's around in your community and what you can use that can actually improve your mental health. We should be thinking about that as opportunities and places you can go, but also other people that could be of support. So A, B, C, D, the asset-based approach, the bit I think is really important about this, that really applies really well to mental health, is about addressing inequalities and building resilience to adversity, and that's what it's been shown to do in other areas. So given what we know about adversity and mental health problems, I think that may well be something we'd want to look at. Just quickly, if you've not been involved in asset-based approaches, it's really all about experts by experience and engaging with people, creating a movement for change. And then, so Southampton's done that by bringing together the people who are most interested, themselves here today, and the group that brought this together, most interested in prevention. And then it's about getting out to the places where people are, that they won't necessarily come to you. And then the co-production aspect of people at highest risk. And then looking at the areas where people, where it's cranked up about people might be in distress. And of course, never forgetting people who have existing mental health problems who want support to recovery, 1 in 4 people, as we know. And we may not be in contact with them through services, because again, we know 3 in 4 people don't attend services, so it's about finding ways to get out to engage them. Some things about evidence limitations. These are my last couple of slides, because I didn't want to give you too many studies to look at, it would have been very boring. First of all, settings. I think Lily talked about this. I certainly talk about it an awful lot. It's a real opportunity. If people are in a place and you're going to be doing stuff to them anyway, it may as well be the real good stuff that you do with them, and do it with them rather than to them. But looked after children as an area that's been neglected, and particularly those transitions out of care, you know, what we can do really to support, and what we can do to create whole systems approaches to the places that children are looked after. There's a little bit of work going on at the moment around, there's a few studies around fostering and adoption and looking at attachment there, but that's a newer area of work. So, but every child needs that safe space to thrive, but you also need that one good person, that person to attach to. So that's no different for looked after children. And I think thinking about it that way, that's definitely where we're not doing all we could do. Preschool, a lot of the evidence is focused more in secondary school, a little bit in primary, early years. But actually those nursery years are really crucial, what we do there, and you know, and how we actually get children to the point of readiness for school, so that they're starting off in the best foot possible. Further education, now there's really promising stuff about around applying a whole university approach, which I think is wonderful. Now we need to get into whole colleges as well, and we need to get it more widely. I think Cambridge are looking at this, but there's a student minds are going to be working on it, it's definitely, I know. But further education, there's quite a number of studies, and one we were involved in, that are showing that it's a really difficult time for people. People don't feel prepared after leaving school and are going into further education, and the stresses feel quite enormous. And residential settings, again, often the most vulnerable people with learning disabilities, severe disabilities, older people, apart from often feeling isolated, but there hasn't been so much of a look at this. We did a review of what we call a landscape paper, a review of the evidence base around prevention, which wasn't aimed to look at the actual content of the studies, it was more to look at the subject matter. So we didn't analyse it, we were looking at what people have looked at. So people haven't done much in these areas. And I think prevention evidence base is growing and emerging, but huge gaps around anything that's more around inequalities. But also, I think there's real areas that, because of statutory obligations, children and young people, there's just been a lot more attention, so there's a lot to think about. The life course, the life course, adults not in work, lots of adults can't work for lots of physical and mental health reasons, are able to work for periods of time. We know about volunteering, but we need to know more about what works for people with mental health problems and helps them to do well and thrive. Later life, as you go up the life course, there's less and less evidence. The time you get to later life, there's really not been that many studies done in the whole public mental health agenda at all in later life, and particularly around prevention, which is, I think, as I said, it's an area where a lot of your life challenges come home to roost, and a lot of people being very isolated. We see depression on the rise there, and obviously we've got this massive issue of dementia that we need to consider, but loneliness and isolation, I think, as well. And transitions, those points where you're becoming a parent for the first time, you're leaving your parents the first time to go into nursery, or you're going into school, primary school, and then you're going into the big secondary school that's infinitely much more impersonal. And then coming out of that, and you've got to make your own way in the world sometimes with very little support to do that. But also into retirement as well, and bereavement is part of that as well. And lastly, mental health inequalities. So I always like to think about this as, I always tend to split social and economic, because I think we can forget the social bit or the social economic when we put them together, which is discrimination, I think, is the biggie, and also adversity. You know, if you're experiencing domestic violence, if you're from a BNE community or LGBT, unless you've been very lucky, you'll have experienced some levels of discrimination that on top of if you do have a mental health problem, gives you a double inequality there, and poverty. And we've just done a report with GRA looking at poverty and mental health, and the evidence base around prevention is not as strong. I mean, it's mostly been poverty and with mental health problems, a lot more to unpack. When you think about social determinants of mental health problems, then poverty, I mean, Ho's right up there, so we need to understand more about what would make a difference. We can't, again, as I said, we can't cure all of society's ills through the work of mental health organisations, but what's the contribution, the piece that we really could do and do well. And health inequalities, again, often forgotten about. Having a disability, having a learning disability, having a long-term condition means that you're at much higher risk of having a mental health problem. And very, very few services like cancer care are now starting to go there to a really good degree. Some of the heart health organisations are starting to really understand this, but there's an awful lot of areas still to be looked at. That when you get a diagnosis of a life-changing condition, there's still not that embedded that embedded holistic approach that, where people are asking those questions about how you feel about it and how you're going to cope and how your family's going to cope. So that's the evidence base, such as it is. A couple of promising approaches, and that is definitely my last slide. So psychologically informed care in residential settings, some evidence base around psychologically informed approaches in prisons, and we've done work in homelessness, and there's a number of these kind of smaller studies around. But neighbourhoods, psychologically informed neighbourhoods, that could be a really exciting area to go. There's certainly neighbourhoods, there's work internationally, so the nurture neighbourhoods in America, where the whole neighbourhood see it as a responsibility to nurture and grow the health and mental health and well-being of children in the area, and they take a whole neighbourhood approach to that. So interesting things to look at, I think. Peer support and mentoring approaches for people, so not universally, but for people who we know are at higher risk of becoming isolated. So lots of areas, we've done a lot in this because it's been a gap, because that as a foundation, that's what we tend to do, is look at where the gaps are and see what we can do. But a lot more needs to happen around carers, as I said, people with long-term conditions, young parents, young fathers as well as young mothers. Trauma-informed approaches, we've got the blue light work that's happening. I've put a bit more information there about what they're doing in Baltimore. They're taking a whole city approach to trauma, so that all the first point of contact services are asking that question, not what's wrong with you, but what happened to you. And assuming at the first instance that if you're presenting distress or you present with a mental health problem, that you're likely to have had experienced childhood adversity and trauma. And they're finding good results with that work. CBT for older people, now it's getting right at the far end of tertiary, but I don't want to miss this because some of the best results are around CBT around IAPT are for older people. But it's still really, really hard as you're older to be able to access that, and there's ability to do much more. There's some preemptive CBT work going on, but not for older people, so I think this could be a really, really good area, particularly at that point of transition where people are really vulnerable and at risk. Integrated approaches to mental health as well. We've done some work on this, but the King Fund very recently have done, so if you look at their report, they've done great work on this, sort of bringing this together in the last year. Look at all the different opportunities to really do well around integrated approaches, and as has the Centre for Mental Health around liaison and diversion. And lastly, digital solutions. So Online IAT, online guided CBT, we know are coming out really well, or pretty well, against other things. Our own online mindfulness course was evaluated and has come out very strong. Self-management approaches, probably more we could be doing, well not probably, definitely more we could be doing there. And probably I'll just end by saying that we've just recently been successful in an EU grant which will allow us to do work across the UK as well as across Europe, looking at bringing together digital approaches to mental health. So it's part of a big consortium we believe in the UK part of it, but it's a chance now for us to start to think through not just what works but also standards and safeguards and all the things that make mental health a bit tricky. So I think watch this space and if you're interested in connecting in with it, we'd be delighted to connect up with you in Southampton and beyond. But a lot more evidence needed there. I can't really say too much about all the different things that work because most of them haven't been studied properly yet. Okay, thank you. That's